Hi, folks. My name's Dave Spooner. I've been a general practice dentist for 40 years. For nearly 30 of those, I have had the pleasure to practice on Bainbridge Island. 2 years ago, I was able to take advantage of the city's Wilderness First Responder Training Program and shortly thereafter became a member of the Bainbridge Island Emergency Response Team. In my 40 years in this profession, I've seen my share of dental emergencies. For some, I've been fortunate to be the first responder. In others, my patient and I have had to deal with choices made by other first responders. So I'm going to tuck myself back behind my PowerPoint screen and for the next half hour, teach you how to respond to common dental traumatic injuries. I hope you find it useful and I appreciate your attention. Thank you.
Now, our probability of being around for the next auto accident is very low, and with luck, we'll not face conflagration, plane crash, or earthquake, but you are going to be around kids. You'll be watching kids or grandkids sports, or you may be playing sports or exercising yourselves, and there's a very good chance you'll come face to face with dental trauma. As a dentist, I obviously have seen my share, and by and large, they were a result of sports injuries. Everything you see here is a traumatic injury waiting to happen. A touch football player may strip and come down on a knee. A soccer player is about to get a ball in the mouth. These young ladies with sticks have very little facial protection. You can always count on a face plant to cause injury. A ground ball here may take a bad hop, and an elbow may go astray. This presentation will give you a few guidelines as to how to proceed. Today's talk will address first responder actions when confronted with dental trauma. I'll cover a wide range. We'll talk about replanting teeth that have come out completely, treatment of teeth that are slightly out of position but still intact, treating with teeth with either major or minor fractures, identifying patients that are beyond our treatment skills but need to be protected from further injury, the difference between what you turn over to the tooth fairy and adult teeth, as well as minor injuries that you can ignore or might even miss. With the exception of a few of my own cases, all of the slides I'll present today make use of photos I have gleaned from the internet. I've done my best to attribute their sources. Other than my membership in the American Dental Association, I have no affiliation with any organization associated with any of these slides. So what am I going to discuss today? Well, we'll talk about teeth that have been completely knocked out, teeth that have been displaced but not knocked out, teeth with chips missing, teeth with parts separated but not missing, and teeth with fractured roots, plus a phone app to help you remember what to do in the case of an emergency. Now, the upper front teeth are the most commonly evolved, specifically the upper two front teeth. And in these situations, 4 patients immediately come to mind. I had a friend who went over her handlebars when reaching down for her water bottle. A baseball player who had a ground ball take a bad hop, hit his upper front tooth, and knock it out. My son when he was struck in the face by a gate, and me when my legs were knocked out from under me during a basketball game when I went up to block a shot. So you understand what you're dealing with when confronting dental trauma. It's important to know some of the anatomy. So with this diagram of an upper front tooth, I will go over it with you. This spongy looking area is the alveolar bone or the jawbone. It's what supports the tooth. The tooth itself has 2 major components, the root and the crown. The crown is covered with enamel, the hard, white, non-innervated exterior layer. The yellow area is the dentin, which makes up the bulk of the tooth. It's what hurts when you are worked on with inadequate anesthesia, and it can sometimes be sensitive when a fracture exposes it to air or water. The pulp, referred to as the nerve by many people, not only contains nerve fibers, but blood vessels connective tissue, and many other types of cells. In the case of a significant fracture of the crown, it may appear as a red spot in the middle of the tooth. It's the source of innervation to the tooth and is particularly painful when exposed. When a tooth undergoes endodontic therapy, or in the popular vernacular root canal therapy, the pulp is what gets removed. The space it occupies is smoothed and disinfected and then filled with inert material. Now, the last structure I want to draw your attention to is the periodontal ligament. This is one few non-dentists have heard of, and it's not a ligament in the familiar tough cord-like sense holding joints together. It's more like a sock around the root of the tooth, acting as an interface between the tooth and the bone. And what you need to know is that it's the periodontal ligament, not the blood supply to the pulp, that is the key to the survival of a tooth that is dislocated or knocked out. So preserving this tissue is the most important non-life-saving intervention a first responder can perform in the mouth. So I will address the periodontal ligament shortly. Now, the World Health Organization defines 12 types of dental injuries. Of those 12, there are 7 that first responders should be conversant with. These first 3 will have the greatest outcome for the patient. One where the tooth is fully out, and the other 2 where the tooth is partially out. The next 2 will make your patient's dentist love you. One where the fracture is minimal and not very sensitive. One where the fracture is significant, exposing the pulp. Whichever confronts you, try to locate the fractured pieces and retain them for the patient's dentist. There are 2 other types, one where there are significant fractures but not detached, and one where there has been a fracture through the root and part of the tooth may or may not have come out. Okay, you come across an injury. You've determined that the scene is safe. You have permission to treat. Your XABCD evaluation is complete, and you move on to your secondary assessment to eliminate any underlying medical causes. What happened? Is the patient oriented? Assuming yes, do your whole body survey to determine whether this is exclusively trauma or if there's an underlying medical condition. Then, for a dental injury, it's important to do a focused extraoral and intraoral exam. The extraoral exam should evaluate the jaws and other facial structures. The intraoral exam should concentrate on looking for tooth fragments, feeling for tooth fragments inside swellings, looking for lacerations of the tongue or the gums. And if there is something missing and it's not in the mouth, is it nearby at the site? Are there some fragments that can be retrieved? Can you get the entire tooth perhaps? If the tooth is out, this is your most important consideration. Can you get it back where it belongs? And if not, can you keep it hydrated to keep the periodontal ligament cells alive? Okay, you are in the area and you see an injury occur. Upon approach, this is what you see. The patient's missing a tooth. There's another tooth chipped. There's blood on the lower lip, and there's a minor laceration on the upper lip. Now, your most important consideration, could the missing tooth and chip be still in the mouth and potentially aspirated? So you must do a quick intraoral exam so as not to turn a dental injury into an airway obstruction. The exam is simple and can be accomplished quickly using a tongue blade. Look back into the throat, lift up the lips, top and bottom, to see if there's anything behind them. Pull back the cheeks to see what might be between the tooth and the cheeks, and have the patient elevate the tongue. And if he can't do that, gently take hold of it with a gauze and lift it. If you find that the tooth is avulsed, time is critical. That tooth must not be dry more than 60 minutes at the very most, and the absolute best action you can take is to clean it and replant it after more than 20 minutes. If you can't replant it, your best choice is either a tooth-specific hydrating kit similar to surgical saline, or put it in milk. Saliva can be a fallback in the absence of others, but be aware that it has a high bacterial count. And it's also important to know how much control a child has over its swallowing reflexes. An older child can probably keep the tooth between the cheek and gum. For younger ones who might swallow it, it's better to have them spit in a cup. In no case should you transport the tooth in plain water. That is going to draw the electrolytes out of the ligament fibers and cause them to degrade. This is the commercial hydration kit that I mentioned in the previous slides. A suspending mesh within this container holds the tooth submerged within the solution in a position to keep it ideally hydrated. And although Save a Tooth is your go-to alternative when you can't get the tooth back in, beware of the caution at the bottom here. It'll buy you time, but will not replace the loss of blood flow to the periodontal ligament. Note that it is endorsed by the American Dental Association, and it is in the first aid kits of all the Little League coaches, as well as in the rotary field equipment shed. Where else on the island it might be, I don't know. If you're a regular at kids athletics, I would strongly encourage you to get one for your own kid. They have a 3-year shelf life, so it is a relatively inexpensive purchase. Now, as parents, what are we used to seeing? We're used to seeing the remnant of the crown after the root has been resorbed. This is what the tooth fairy collects, less than half to a third of the fully developed tooth. You can see here that the majority of the fully formed tooth is buried within the bone. And although the relative sizes between primary and permanent teeth are different, the relative proportions of crown to root length are not. As I said, most of you have not been able to appreciate the proportions of a permanent incisor. The baseball coach who was present at the ground ball event I spoke about earlier thought that a piece of wood had fallen from somewhere when he saw it. Now, for those of you with clean hands, let's do a demonstration so you can feel this structure yourself. Put a finger on your upper front tooth and run it straight up over the gum, sliding upward, and you can go back and forth, feeling the convexity of the root surface underneath the alveolar bone. You can feel it go up till it terminates just under your nose. Now compare that length to what you're used to seeing, the crown, compared to the mass up here buried within the bone. Now here's a situation with a fully avulsed tooth and what you need to do and do promptly. The teeth on the left are freshly extracted. The one on the right, the periodontal ligament, has been cleaned. Now the periodontal ligament on an avulsed tooth should be made as clean as possible before inserting, but you shouldn't scrub it. So rinse it in water for no more than 10 seconds, and in this case plain water is okay as long as you limit it to 10 seconds. If you have an open container, wiggle it gently back and forth. If all you have is a water bottle and there's water in it, flush the surface. Now, this might seem unnerving at first, but all you're doing is putting an oval peg back in an oval hole. It goes easily and smoothly. If not, don't force it. Here, the tooth has been grabbed by the crown. In the bloody environment of an injured mouth, it can be quite slippery. So as you see here, use gauze for traction. For the last thing you want to happen to a nicely clean tooth is to have it slip out of your hands and go scooting across the pavement. If it doesn't go in fully, there's something else in the way. Put it to place as best you can, but as I said, don't force it. Once you have it in, have the patient hold it in place with gauze. If you can't get it in, store it for transport. Now, I would like to get a little technical at this point to show you the difference in outcomes between immediate replantation and delayed replantation. This is a patient who I'm going to call Justin, the subject of the case at which I was fortunate to be present. A ground ball had taken a bad bounce and had struck him in the mouth, and this tooth had been knocked out and fortunately dropped into his glove without having touched the ground. It was very easy for me to pick it up and reinsert it, all in less than a few minutes. And in this photo, taken a few days after the accident at his dentist's office, you can see the gum tissue in good condition and the tooth splinted in place with some temporary restorative material on each side that I had applied. Now, something worth noting here, and I bring it up because it can be a potential problem. In many situations, the patient's emotional response can be very distracting. I actually found it to be the case in our live first responder drills, and it was very much the case here. Justin saw the blood, felt the hole where his tooth used to be, and became nearly uncontrollable, wailing that he had lost his tooth for life. Once I was on the scene, it took just a few seconds to replant the tooth, but it took many minutes to bring his emotional level back down to where he was able to be cooperative. I really want to drive a point home here, so please bear with me as I get a bit technical. Here are some x-rays. The first one taken a few days after the accident, and the two on the right 4 months later when a root canal was performed. Now again, here's the anatomy that I showed previously. Now, going up to the x-rays, compare the well-defined periodontal ligament space, this black line blown up here, days after the accident, with the same structure 4 months later, as indicated by the green arrows here. You'll also see on the far right here, the root canal filling. This is an inescapable consequence because the loss of blood flow when this vasculature is ruptured, when the tooth is knocked out, can't be reestablished. However, in no way does this compromise the long-term retention of the tooth. Root canal therapy is a common, dependable procedure, and because the periodontal ligament was preserved in this case, there's no reason why this tooth should not be retained for the rest of his life. Now I'd like to draw your attention to a case in which replantation was delayed. In this case, a woman was on her bicycle and was slowing to come to a stop at a stop sign. She reached over for her water bottle and in doing so inadvertently hit her front brake. And although nearly fully stopped, she went over her handlebars face down onto the pavement. Her front tooth here was knocked out. Irrespective of her request to be brought to my office, the EMT response protocol, and an appropriate one, was to transport her to a trauma hospital for evaluation subsequent to the head injury. They instructed her to put her tooth into her pocket, where it remained for 6 hours until she finished her evaluation and treatment for her injury. Only at that point, with the periodontal ligament thoroughly desiccated, was she taken to the hospital dental office for tooth replantation. Had they been aware of the necessity for prompt replantation, the outcome you see on the x-rays here could have been avoided. Now, this first x-ray from 2001 was taken 4 months after her August accident. And if you will recall where I pointed out in Justin's x-rays the periodontal ligament, let's look and see what we see here. Now, the tooth on the right was traumatized enough to need a root canal, but it remained in place. And you can see that a periodontal ligament space still remains. The one on the left that was knocked out and desiccated There is no periodontal ligament space. And as you can see in the x-rays that transpired over the next several years, the bone essentially saw the tooth as a foreign body and began to erode it. So although there's no periodontal ligament here, the tooth looks okay. Here we begin to see a little darkening. Here it's quite apparent. And at this point, the possibility of a fracture was imminent. So I sent her to an oral surgeon who extracted the tooth and put in an implant. Now let's go one step further to hammer this point just a little bit more. Justin had the tooth reimplanted on site. If he'd been transported to the dentist, there would have been an exam charge. The tooth would have to be splinted in place, and after the tooth is restabilized, a root canal done. Very straightforward, and that is the entirety of his treatment. Now, in Jane's case, the tooth ultimately was lost, but by the time it was lost, it was fused to the bone. So initially she would have had basically the same treatment as Justin. Then with a fused tooth, it's a significant surgical procedure to get the root out and then graft bone back in that space. That is not done easily, so it's done under general anesthetic. Okay. At the same procedure, generally the implant can be placed, but that implant can't be restored for many months. So with a front tooth missing, you have to have something to hold the space. So we create a temporary partial denture. Somewhat like an orthodontic retainer, but with a tooth on it instead of wires. Then she goes to a different specialist 4 months later for her prosthetic exam and diagnosis. And once that's done, the crown is placed on top of the implant. So, what do we see here? $1,700 in treatment, almost $8,000 in treatment for the loss of 2 minutes on site to put that tooth back in the mouth. So as my grandmother used to say, when talking about darning socks, a stitch in time saves 9. Now things are different for a primary tooth or a baby tooth. There's a permanent tooth here waiting in the wings that can be easily damaged. And since the life of the primary tooth is only a few more years, whereas the permanent tooth will remain for the patient's whole life, don't risk long-term loss for short-term gain. If the primary tooth is out, leave it out, and best of all, your patient may be the first in his class to get a visit from the tooth fairy. If you're dealing with a child who's lost a permanent tooth, be aware that the permanent tooth does not erupt fully form. It may look a little different from what I showed you a few slides earlier. It's going to have a much blunter root and a much larger opening at the end. It takes 3 years from the time of eruption until the root develops completely. But that doesn't change the protocol. Get the tooth clean and get it in. If an injury causes a root fracture, the tooth may or may not come out. If it does, an avulsed tooth with a fractured root will have sharp edges and a flattened end rather than the rounded end that you see in a fully avulsed tooth. Nevertheless, the replantation procedure is the same. The fractures can occur at any one of a number of levels. If it occurs in this area, there's a good chance that you're not going to be able to keep that fragment in, but do hang on to it and send it with the patient to the dentist for treatment. The procedure is similar on a partially avulsed tooth, though not identical. If you find it partially out, gently try to push it back in until the incisal edges, marked by green lines here, even up. It will either go back easily or if it won't. If it doesn't go back in easily, you probably have a situation, as you see here, where part of the tooth has been dislocated while the anterior face of this alveolar bone has fractured out. So this is not easily put back to place in the field, so stabilize it as best you can and get the patient to dental care. Now this is another non-urgent case. These fragments were detached but were collected and turned over to dentist, providing him or her a great service. And although the aesthetic characteristics of the materials that we have today are pretty amazing, even so, it is much easier to rebond missing structure than to rebuild it. So look for the missing pieces and collect them. And here you see the finished case. Note how the very nice anatomy was retained, the diffuse reflective surface, nice incisal translucency. This is much more difficult to accomplish when you're restoring with artificial materials. Here's a situation where a patient has experienced a fall. After noting his swollen lip, take a look inside. You see the tooth with multiple fractures visible, but nothing obviously lost. That means the fragments are still attached to the gum behind, as we see in this WHO designation here. In this case, the loose fragments should be supported in place with gauze. You want to palpate this swelling to make sure there are no chips inside. If you feel anything suspicious, leave it in place, but pass your findings on to the next caretaker. Although this is a visually alarming case, with timely referral to a dentist, it can be treated to a good outcome. Now here's someone who was struck in the face with a garden tool. Although dramatic, it's also non-urgent. Although in palpating the upper lip in this case, there is a foreign body that was felt. So the information was noted and passed on. And later in the dental office, this is what they found in the x-ray. These fragments came from this spot right here. Now, these are severe injuries, well beyond the first responder's ability to treat. The first one was from an automobile accident. We have missing central incisors. We have a fractured lateral incisor with a root remnant, and the other lateral incisor is partially avulsed. In this case, this was a young man who turned around and was struck in the lower mandible with a baseball. This whole bony segment broke free, but on examination it doesn't appear that anything else is missing. So, first responder action. Do your secondary eval to determine if any other treatment is necessary. Okay, and then, as we had discussed earlier, look for fragments or loose teeth to prevent aspiration. Back in the throat, under the lips, inside the cheeks, under the tongue. Secure these loose fragments as much as possible, these loose sections as much as possible with gauze, but realize that the patient is severely injured and may vomit, so the gauze has to be easily removed. You may have a case here where the patient passes out, so in that case it might be necessary to put them in the recovery position. This is a very handy and well-designed cell phone app that can be downloaded to either an Android or iPhone. developed by the International Association of Dental Traumatology, the experts in their field, and these guidelines cover all that I have discussed today. It certainly would be an ideal addition to your armamentarium. I've downloaded it and find it both comprehensive and easy to use. Here are a series of screenshots I've taken from my phone, and you can see, say in this case, I have an injured tooth, and then here are your choices. And it's what we've covered today. The tooth has been knocked out, the tooth is moved, it's been pushed in, it's loose, it's fractured, there are facial injuries, or there's major trauma. So looking a little more closely, here's for one that is avulsed. And here are the steps we walk through. Okay. Missing tooth. Get it in within 20 minutes. So find it, hold it by the tooth, or hold it by the crown, rinse it briefly, and put it back in. Hold it with gauze to maintain traction, and then hold it in place with gauze. If you can't get it back in, get it in something, and remember, never put a baby tooth back to place. So in summary, be a hero to mom or dad or to your patient. If a tooth is knocked out, get it back to place. Or be a hero to your local dentist, find the missing chips and send them with the patient. Consider adding Save a Tooth to your first aid kit and Tooth SOS to your phone. And here's my contact information. Feel free to drop me a line on my email or call me on my cell phone. I never answer calls from numbers I don't recognize, so leave a message and I'll get back to you. Thanks for your time. I hope you found this informative.